Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey, it's Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Arizona Hearing Center. I help patients treat their hearing loss so that they can connect better with their family and friends and remain independent. The reason I'm so passionate about helping patients is because I lost my brother Robbie twice. First from his hearing loss from radiation for his brain tumor, and then again when he passed away. I only care for ears. I'm the ear of ENT and performed over 10,000 ear surgeries over the past 20 years. I'm the founder of Arizona Hearing Center. I'm the author of Listen Up, a book about hearing loss. Go to listenuphearing.com. And if you want to ask me or contact me, go to azhear.com and can contact me with any questions. So today I'm really excited because we're connecting with Dr. Francisco Ponce. He's a colleague of mine at the Barrow Neurological Institute, otherwise known as the BNI. I've been there for 20 years practicing in ears, and he's a neurosurgical colleague at this world-renowned BNI. He went to college to Harvard Medical School at University of Chicago, and then he did his neurosurgery training here back at Barrow. He's helping train future neurosurgeons. As the program director, he runs the Residency. He's also an excellent physician, husband, father, and friend. His area of practice is a fascinating field of stereotactic and functional neurosurgery. We're going to explore his expertise and passion on Listen Up. Dr. Ponce, welcome.
Thanks, Mark.
Sure. So, tell me your pathway to neurosurgery and the specialization. I'm always fascinated how people end up where they end up. So, that you probably weren't born saying, I'm going to be a functional neurosurgeon. So how'd you get there?
Yeah, I think like a lot of people, it's kind of the environment you grew up in. My father was a physicist. He worked at it was a Polish Research Center, Xerox. It's where the mouse and the Ethernet and the laser printer and the digital user interface were first invented and never commercialized.
Right.
He had one of those jobs that he never felt like he had to work a day in his life. It was like every day was play. And I thought that's what I wanted to do. I did physics as an undergrad. And I remember my father basically saying, this job I have doesn't exist. Like you can't plan for this. And my mother was a nurse, and she had spine surgery when I was in high school. And I remember that's kind of at that point, before high school, because from then on, my brothers and I divvied up laundry, garbage, and dishes. And once you recovered, we kept doing that. So we kind of, even now, today in my home, those are the responsibilities that I cover. So I kind of went in with this passion for physics and sort of this practicality, right, for medicine. And a lot of my experience with research as an undergrad was the frustration. I remember when I was a researcher once said, if it's not frustrating, it's not research. And I think the idea with neurosurgery was kind of that interface, the potential for interface between sort of the physics, the biophysics, the biological physics, and the immediacy, the gratification of going to work each day and helping somebody within a finite amount of time and finishing that day with that behind you.
So it's cool. It kind of wraps up both of your passions into one thing, and you get to help people. That's a pretty cool combination, it sounds like, for you.
Yeah, we all kind of create these narratives, right, of our trajectories and how everything gets tied together.
It's good.
Even with neurosurgery, at one point it was clipping aneurysms that drew me.
Right.
And it was actually talking to a friend from college years after, who's a physics professor at MIT, where I could not really kind of convey that next level. What was so cool about clipping an aneurysm,
right.
Highly trained monkey. And it was right around that time when kind of that switch occurred to what I currently do, which is neuromodulation, deep brain stimulation.
Yeah. So tell me what that is. It puts it, your stereotactic and functional neurosurgery. It's a cool word, but what does that encompass? Because I think when a layperson reads it, I'm not sure they know what that all means.
Yeah. So deep brain stimulation, I think similar to cochlear implants, these are neural interfaces, right? We're tapping into the brain circuitry to improve life, right? And it's, I think one thing with neurosurgery, when people think about brain surgeons, they think about life-saving surgery. What I do with deep brain stimulation is life-changing surgery. And it's
right.
that people can regain their independence, improve their quality of life, very similar to kind of what you see your patients experiencing after a cochlear implant. And we use technology it's like a brain pacemaker. It's very similar to what you imagine as a heart pacemaker, but instead of the wires going and tapping into the nodes of the electrical circuitry of the heart, they're actually going in the brain, about 4 inches into the skull, straight into the nodes that are part of the neural circuitry.
Oh, that's really cool. So actually when I think about cochlear implantation, it's, physiologically or electrophysiologically, that's what happened. But, the way hearing loss affects people, it affects people's overall wellness. Right? Does that make sense? And so I suspect you are in a lot of ways like a wellness neurosurgeon, right? Because you're restoring people's wellness. So tell me about, the diseases, how they impact people, and then how you're able to reverse them or restore them to wellness, right? Because people aren't just interested in having the aneurysm go away. They actually want to be able to regain or restore functionality.
Yeah. A lot of these diseases kind of are insidious, right? It's like a water hammer effect. You get the diagnosis of Parkinson's because you're shaking,
right,
or you're a little bit slower, and you kind of slowly adapt to that new reality. And then something else builds upon that. Now you're shuffling, you're not able to, you're not able to work anymore. You go on disability. And then eventually, you kind of figure out, I don't feel comfortable going to restaurants anymore with friends because I don't know if my medicine's going to be working or not. And then even relationships at home can evolve into sort of, they say disability can be the glue that keeps a family together, where the relationship at home becomes one of caregiver, patient caregiver. But that doesn't happen overnight. It doesn't happen over the course of a year. And I think with things that the two primary conditions I treat with neurostimulation, with deep brain stimulation, are Parkinson's disease and essential tremor.
Right.
These conditions are conditions that, again, can be gradual and things that people adapt to, learn to live with, resign themselves to. And in terms of wellness, the motor benefits that we give patients to these therapies are enormous. But if we wait too long, they've become sort of socially deconditioned, such that those benefits they receive, they may be unwilling or unable to apply them to improving their quality of life to the degree that they could because of that social decondition that takes place.
Yeah, it's fascinating. As I listen to it, you're hitting on the exact same impacts of hearing loss. The two analogies I use, one is it's death by 1,000 paper cuts, right? So, it's a slow, deadly thing. Or the other thing I always say is like, how do people get to weigh, 500, 600 pounds, and it's all 1 ounce at a time, right? It's not like you go from, weighing 170 pounds to those that are overweight. You slowly get there. And then one day you wake up and you go, oh my gosh, I'm totally not functional. So it's of the same nature, a gradual erosion. Yeah,
that's what it is. It's an erosion. And that's where we kind of look at these windows and try to define based upon the safety of the operation, the efficacy, better clarify when the optimal time point for treatment is.
Right. So how far down the functional deterioration do they go where you've got enough upside to do the procedure?
Mm-hmm. Yeah.
Well, speaking of that, so tell me like one of your best patient stories. Like, we all have these times where like, a patient says something or there's a profundity that comes up. So I'm always fascinated, like, we all have those. And so what are yours? Like, tell me one of yours.
So I had a patient come in from out of state. She had not been able to apply mascara for years, unable to bring a cup of coffee to her mouth. And she had essential tremor. And we placed the leads. And just by the micro trauma of inserting the leads, she woke up she came out of surgery that evening. The next morning, she's drinking coffee.
So she wasn't even turned on yet, right? They weren't even electrically stimulated.
We have to separate battery and the leads just with insurance. So even just with the operation, she was able to do things that she had never been able to do before for years. And went home. So when I saw her a few days later for the battery, she was raving about all these changes. And so we continued the battery. And the reason this stands out is because a couple of weeks after she went back home, I get shipped in, dry ice, king crab legs and salmon, and it was just incredible. So I shared with my office, and we had a feast.
I think the amazing thing is that's like such a wonderful gesture on that patient's part, but probably doesn't even come close to expressing the profundity of how her life was changed.
Yeah, no, it's one of those things that the way I see it is these are chronic conditions, right?
Right.
And I'm a very small part. I'm this, focal point in this journey, but it's a brief period. This therapy, it's kind of like what I imagine might be similar to kind of what you offer. When you think about a heart pacemaker, you're not really thinking of a surgical treatment for heart arrhythmia.
Right.
It's electrical therapy, but you need an operation. It's hard to even call a pacemaker placement as surgery.
Right.
Now, obviously, here we're drilling holes in the head, we're putting leads in the brain, but the mechanics is very similar to that, and it is ultimately an electrical therapy. So my job is to offer the operation in a safe and consistently effective manner so that a neurologist can offer this just like they would offer medication.
Right.
It may have side effects, may not be effective, and the safer and more consistent outcomes I can offer with this therapy, the more popular it will be for the clinicians actually managing the symptoms, the neurologist. And so the effort, put into how to kind of go about packaging and delivering this therapy is how to kind of address that journey a patient has in their lifetime so that this part is done well and is accessible so that afterwards their quality of life, just their enjoyment of living improves.
Yeah, I would imagine. I mean, I don't wear mascara, but that type of fine motor coordination and not being able to do that must be, especially if it's something you did your whole life. I mean, drinking a cup of coffee is a pretty normal functional thing to want to do.
Another one of my patients, a really dear patient of mine, his goal was to walk his daughter down the aisle for her wedding. That was several years ago.
No, that's why we do it, right? I mean, that's the human connection to the disease, right? I mean, we think about the therapy for the disease. They think about the benefit of the therapy, right? So you think of stopping the tremor. They think of walking my daughter down the aisle. And as you think about it, certainly stopping the tremor does not give me the emotional feeling of me contextualizing me walking one of my daughters down the aisle and how important that would be. And that's awesome. I mean, that's why we all get out of bed every day, right?
Yeah.
So there's all this great stuff happening. Like, what's the future in this field? So you've got essential tremor and Parkinson's. What else are you guys working on?
Yeah, so the big one that we've been working on at Barrow is Alzheimer's disease. So I think that the frame shift, it's kind of a paradigm shift to think of Parkinson's as a surgical condition, right? I mean,
right.
Really maximize your quality of life, you get surgery. But as this operation, they always show in the news like futuristic or 21st century medicine. It was first done in 1987. For movement disorders. It's nothing new. But it's given, because it's worked, because we've had FDA approval for over 2 decades, all that. 97 was for essential tremor, 1997 was approved. We've had the opportunity to kind of tap into these networks through established on-label treatments and start and listen and learn more about these networks. So I think there's been a shift in terms of how we understand brain disease, whether it be depression, Alzheimer's, from targeted areas of degeneration to how the circuits go awry, become dysfunctional as a result of those degenerations. And so we're looking at Alzheimer's disease. We know about plaques, the amyloid plaques, but looking to see how we can rev up the memory circuits with modulation as a treatment for cognitive disorders. So we're one of the largest centers in the country, in the world, studying this. We're actually participants in a phase 3 trial, which, as you know, is the last step you do before you would get FDA approval. And it's called the ADVANCE trial. And it's a study looking at, basically it's the same operation I do, except it's all in the planning on the MRI. I get the MRI and I pick a different target. So we're using a memory target instead of a motor target. And we've treated about 16 patients so far at Barrow for Alzheimer's disease. So I think that's exciting because there's very little so far as alternatives go to Alzheimer's. Nothing works right now. And I think that's been one of the challenges we've had with other conditions like depression, where there's so many medications and interventions that are approved that you need to exhaust, because when you start looking at experimental indications, novel indications, you're moving away, you're going in the direction of treatment of last resort, right, versus kind of the sweet spot we're in with Parkinson's and essential tremor, which is where it's not, we already know it works so well and that it's safe that you're not waiting until to use it as a last resort therapy.
So you're getting the hardest cases, not the easiest.
Well, that's been the issue with depression. We don't have that issue as much with Alzheimer's disease because of how few options they have.
There's not a competitive therapy.
Mm-hmm. Right, exactly.
Yeah, so it's interesting. I mean, we're again looking at the similarities. The hearing space is coming at dementia and Alzheimer's from a cognitive load point of view, right? And so if you aren't getting the information into your brain via hearing, you have to use secondary mechanisms to communicate, and you have a cognitive overload plus social withdrawal. So we're treating the hearing loss with the same intention, just coming from it from a acoustic stimulation point of view, and you're coming from it from an electrical stimulation at perhaps the end organ of the disease. So it's, that for us, the correlation is pretty clear that untreated hearing loss is associated with a higher incidence of dementia and memory problems. That's, and so there's actually a study in Lancet a couple of years ago where they talked about what you can do to reverse cognitive issues and dementia issues. And so it was like, stopping smoking, cholesterol, obesity, those were all like 0.1. Hearing was like 8, an 8-factor improvement. Right. So it's interesting. It'll be interesting to see where you fall in that spectrum for specifically Alzheimer's, and whether or not you guys change, what upside you give. That'll be great.
Yeah, another area that intersects, and we've talked about this before, but people keep asking me about is tinnitus.
Right.
And we've chatted about that, but where ultimately there's been some studies looking at neuromodulation for tinnitus, like neurostimulation.
On the cochlear implant side, it does attenuate it in a decent number of patients. The hard part we all have is tinnitus, cochlear or central. And so certainly you'd be targeting central. The problem is we don't really have a good test to say, I guess, are there functional electrical tests that you can do to show where there's functional electrical brain activity or something? Can you measure that?
For hearing
or anything? Like, is there a way you can measure the electrical activity of a person with an imaging technique of the brain? Now I'm really getting out there. I don't know.
Yeah, I think we go more with, the glucose metabolism, how.
Right. So that might be what we'll eventually need, is some sort of electrical mapping. So if you could get on that and have that by next week, I'd really appreciate it.
Yeah.
Or maybe your dad can go to Xerox Park and do it for us there. So tell me, who are some of the other colleagues who are advancing or working on this brain wellness issue, maybe from other aspects, right? So I think even Alzheimer's should probably have to take a holistic approach, right? Like, so for instance, I would hope that, I would know that those Alzheimer's patients have their hearing loss treated, for instance. So who are the guys doing other work in this area? Dementia is such a big issue. Who are the guys that are doing that kind of work at Barrow and stuff?
So Dr. Anna Burke, she's been one of my key colleagues throughout. Back when she joined Barrow several years ago, but she was with the Banner Alzheimer's Institute prior to that, and that's when we first initially started collaborating it was the phase 2 trial of deep brain stimulation for Alzheimer's at that time. And then and Alex Troster, he's a neuropsych. So Anna Burke's a psychiatrist who specializes in Alzheimer's disease. And then Alex Troster has been a key colleague of mine for 9 years now, and he. We recruited him right when I started here, and he's kind of the premier expert on the neuropsychological screening and consequences of neuromodulation.
Oh, that's cool.
It's been part of pretty much every big.
So you do pre-therapy and post-therapy testing?
Mm-hmm. Yeah.
Do you see any changes beside? Well, I guess it would be if your Parkinson's goes away, your neuropsychology testing should maybe improve.
Yeah. Well, we often think of Parkinson's as being the motor component, but there's a very large cognitive component in the kind of later stages. Most of our patients that we do deep brain stimulation on have some mild cognitive impairment. So that is a huge part of sort of where they are in the course of the disease, how much of an impact cognition has and mood on the quality of life. That's
probably where the idea to do it for Alzheimer's might have come from, right? That you're seeing some cognitive improvement in Parkinson's.
Yeah, we're actually seeing, we have a pilot study, smaller study looking at treating patients with mild cognitive impairment. with similar strategies for neuromodulation, revving up those memory circuits when they're going to surgery already for their motor symptoms of Parkinson's.
Well, that's pretty cool. So, tell me a fun fact about you.
Well, before I got I overwhelmed with home responsibilities, I used to be very, my thing was super long distance activities. So I've done an Ironman and I've double crossed the Grand Canyon. That's like a 40 mile back and forth. I've done that 3 times now.
A rim to rim to rim?
I feel like rim to rim to rim. But I feel like there should be a statute of limitations on those kind of feats. The further away, it's been less than 2 years since the last time I did that. That used to be my thing. I think I stopped going on those super long runs when I realized my son became a teenager, and
you didn't have the time.
3-mile run. Let's go do a 3-mile run. At one point, he's like, "Dad, are you going to go do another 10-mile run?" And I'm like, "No, let's do a mile and a half. Let's go together." So.
Yeah, so I've done a rim to rim. So our characterization was rim to crazy. Right. That second time back, you're going out and people are coming back in, at early afternoon. It's intense. So good for you.
When I was a medical student, and that was the first time I did rim to rim with Robert Sputzler, the prior chair of BNI, world's greatest neurosurgeon. We finished the rim to rim together. And, this is how I got to connect with him as a medical student. And he pulls out 2 ice cold Bud Lights. And right as we're about, one for me, I was like, I'm going to beer with Robert Sputzler. This is like a medical student's dream. And right before we crack it open, we see these 2 hikers come up the rim with their walking sticks and turn around and just go right back. And it was so tempting. And he's like, what do you think? And we crack open the beer. And that was like the best beer ever, especially after that hike.
Yeah.
And his car completes they take off. And I end up waiting 6 hours for the last person from my car to arrive. And that was actually when I was like, you know what? I'm never going to wait on the North Rim again.
Just go back down to the South Rim yourself.
Like that,
yeah. I stayed over at the North Rim. It was nice. So you could watch the sunset over, and you're looking at the sunset and looking at the other side and say, wow, I came all the way from there to here. So it's a pretty amazing experience.
It's a distance. Yeah.
Yeah. Anybody who's watching this who's not from Arizona or been here, the Grand Canyon is a must do in life. I'd say it's a bucket list thing. So.
Yeah, I think it's a balance. I know in terms of like how hiking the Grand Canyon is an incredible way to experience the Grand Canyon.
Correct.
And you got to stop and look up sometimes, especially when each step you take matters. You don't want to twist your ankle and ruin the rest of your day.
Right. So, it's a question I like to ask. So let's say you're giving, the Lifetime Achievement Award or something. And so who do you thank? Like when you think, like, who are those people I thank for getting me here?
Well, I think like you, I've got kind of my wife and we're a team, and it's sort of this the enterprise, right? And we met in college. We were a fire door, in these dorms, they have these fire doors. So if there's a fire, you could, go to the next door. And we had a fire door that separated us. And I met her like halfway through the year. And she's she's a judge. So like we've talked about, the honorable goes before the doctor.
Right.
So, that's been kind of, we have 3 sons and she was actually the one who I had convinced to come to Phoenix. So, after my wife, next would be, Dr. Sputzler. And I think he's one of those inspiring figures that kind of shifts careers and draws out of you more than you could have drawn out of yourself had you not had some kind of mentor like that.
That's great. So we've been talking to Francisco Ponce, who's a world-renowned neurosurgeon. How do people get a hold of you or connect with you?
The website, it's Francisco Ponce Barrow, and our office number is 602-406-3242. So.
Yeah, well, that's a pretty good way to get a hold of it. All right, Francisco, thanks a lot. I really appreciate your time here. It's been a great conversation.
Thanks, Mark.
Thanks, man.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.